Okay.
I still can't see, but Nicole says it's Roger. Okay.
All right. Moment. All right. Hi, everyone. Good afternoon. Thank you so much for joining us today. We'll begin the webinar. Again, good afternoon, everyone. And just thank you for taking the time to join us. I want to welcome you to our webinar on pediatric innovation and gene therapy advancement. Today, we'll be hearing about how involving therapies are being used in the care of pediatric blood disorders and how both clinical management and newer treatment options, including transplant and gene therapies, are supporting children and family. Today, our presenters will help provide a clearer understanding of these conditions, current approaches to care, and the advancement that are shaping treatment decision in pediatrics. So we are proud to be joined by two experts from the Joseph M. Sanzari Children's Hospital at Hackensack University Medical Center. With Dr. Barbara Spitzer. She's a pediatric hematologist specializing in transplant and gene therapy-based treatment approaches, as well as Dr. Stacey Rifkin-Zenenberg, pediatric hematologist, oncologist, and specialist in pediatric hospice and palliative care, focusing on clinical management of pediatric blood disorder. So thank you both for being with us today and just sharing your insights on this. At this time, I'd like to turn it over to our presenters to begin the session today.
Oh, thank you. Welcome everybody. Our objectives today are going to be that the learners will be able to demonstrate an understanding of biology and pathophysiology of sickle cell disease. They're going to be able to demonstrate an understanding of medical management of sickle cell, and also they'll understand the utilization of transformative therapies, including curative options for sickle cell. So I think we have to first start out with understanding the biology and pathophysiology of sickle cell before we talk about curative therapies. So I think everybody understands it as a multisystem disorder. It's caused by the presence of hemoglobin S. Usually it's in a homozygous SS or in a compound heterozygous state. When we look at adult hemoglobin, it's usually made up of two alpha genes, which make up the hemoglobin A, two beta globin genes, which make the beta chains. And then there's fetal hemoglobin that, as you can see at the bottom, is more prevalent at birth. And then as you get older, it's basically a variant of the beta gene. So the founder mutation in the beta globin chain causes P.E6V, which generates hemoglobin S. And sickle cell disease occurs most commonly from hemoglobin SS, but we see it in hemoglobin SC and S beta 0 thalassemia. These are the two more common of the compound heterozygous variants. So if you look at this, this cartoon that we have of the biology and pathophysiology, the top with the person with what's called the HBB genotype is a patient who has normal hemoglobin, has two normal beta globin genes. They make nice biconcave discs, and they make a normal hemoglobin A that has the two alpha and two beta chains. The next patient, as we move down, is a carrier of the hemoglobin S. So they would have what's called sickle cell trait. Their cells still look like biconcave discs, but one of the beta globin genes has a mutation in it as it looks in the circle next to the hemoglobin AS. The next patient, as we move down, patients who have sickle cell anemia, which for our purposes really would be the homozygous condition of hemoglobin SS, have two variants in the two beta globin genes. And this actually causes, as you go down the right side of the slide, it causes the cells which in the oxygenated state are nice biconcave discs, but as they get deoxygenated, they make those sickle cell looking cells. And that's what causes the end organ damage that we see. You'll also see that they also create this hemoglobin S polymer that we'll talk more about. And then as we go down, there's more of the compound. sickle cell types. So hemoglobin S sickles in the deoxygenated state, as I said, leading to a variety of complications, and it leads to anemia and endothelial dysfunction and inflammation. So this is a great picture from JAMA, and it actually shows both phenotypes that we know of. There is the phenotype where recurrent sickling that happens from the oxygenated to the deoxygenated state causes hemolysis, and then with the free hemoglobin, which is scavenged by the nitrogen oxide, it causes vasoconstriction, and that causes the painful crises. The other phenotype that happens is that the recurrent sickling can cause very sticky cells. They cause cell adhesion. The white cells and the platelets will kind of come to that area also, and you end up with vaso-occlusion, and there's a huge inflammatory reaction causing that clogging of those vessels and causing end organ damage. So there's really two things that are happening in most patients. So where do we see sickle cell disease worldwide? It emerged from the malaria belt, and it was a selective advantage for S trait due to its relative protection for cerebral malaria. We know that there's about 8 million people worldwide living with sickle cell disease, and there's about 300 million people worldwide having sickle trait. But in the United States, we suppose that there's about 100,000 Americans. There hasn't been any actual registry done, but we can say that there's about 1 in 365 African-American births. There's 1 in 16,300 Hispanic births. And we know that 1 in 13 Black or African-American births have sickle trait. And these are really from the newborn screening tables. This shows really why patients who have sickle cell disease should be considered for these curative and transformative therapies, because it causes high morbidity and high mortality. And the median life expectancy in the United States for sickle cell is about 52 years. This has not really changed in the last 40 years. It's often sudden. In addition to acute and chronic pain, they can have end organ damage. And if you look at the cartoon on the left, every single system can actually be affected. And most of this damage ends up being life-threatening, affecting pulmonary, cardiac, renal, CNS disease, and more. So what do we do in pediatrics? In pediatrics, we've really started early, and we've improved the outcomes in pediatrics. We have not pushed the mortality age, though. So we've done early screening. So we do prenatal screening and newborn screening to identify affected infants, and that's where all of the newborn screens across the country focus on. And then they lead to the early prevention strategies. By identifying patients, they're identified to pediatric hematologists so that they can have penicillin prophylaxis, immunizations, transcranial Dopplers to identify patients for stroke, and transfusion therapy in patients with history of stroke. For many years, we've used for disease-modifying therapies, we've used hydroxyurea, and this was really the only medical therapy. It increases hemoglobin F. We know that it decreases the hemolysis part of that pathophysiology. There's less sickling, and we know that there's a lower risk of severe complications long-term. Some newer treatments that have been approved since 2017 are L-glutamine, which is a type of protein, which is an anti-inflammatory. There was voxelotor, which has now been withdrawn off the market. And then there's crizolizumab, which is a p-selectin inhibitor. But again, these disease-modifying drugs, if you look at all of these, they don't really address all of our organ systems, and they don't really address mortality. In a lot of the drugs, there hasn't been evidence, or we really just don't even know if they affect the organ systems. And really, I think what we have to focus on, quality of life now in pediatrics, but also as children age out into the adult world. So really, only curative therapy historically from the early 1980s was hematopoietic stem cell transplant.
So I'll start talking now. So Stem cell transplant is the only curative therapy for sickle cell disease, has been for a long time. And the way, the mechanism by which it's curative is by replacing all of their blood-forming cells with new cells from an unaffected donor. So that's the basis of transplant. The first stem cell transplant for a patient with sickle cell disease was in a patient who happened to have sickle cell disease who developed AML. In 1983, underwent a stem cell transplant for their AML from a matched sibling, and they were cured of their AML. And to the surprise of the investigators, of the treating physicians, her hemoglobin pattern changed and converted to that of her brother's sickle trait. This was a long time ago. It's a little surprising how much of this knowledge is relatively modern. And she stopped having any crises. There's actually she has a little video online if you're interested. And trials throughout the 1990s continued to look at matched sibling transplants for patients with sickle cell disease. And they kind of became the standard of care for young patients with sickle cell disease. And as of 2013, and now there have been many more, but there were at least 1,000 matched sibling transplants performed for sickle cell disease. And you can see the outcomes for patients with sickle cell disease. So on the bottom, you have overall survival. These are different graft types. So we really use bone marrow is in the red, or cord blood from a matched sibling in the green dash. The green dotted, and these really have excellent overall survival many years post-transplant. The rates of chronic GVHD, which is a kind of a chronic complication of transplant, rates are very low. So these are excellent outcomes. And this is why stem cell transplant can now really be offered to any patient with sickle cell disease who has unaffected and HLA matched siblings. But we have to consider not everyone with a matched sibling, siblings has a match. Not everyone has a matched sibling. We'll talk about that in 1 minute. And there are other things that kind of may complicate the course of transplant that we have to consider when we're talking about stem cell transplant for sickle cell disease. So looking at related donors, how do you know if a patient is a match? So what's important to realize is that the HLA types are all inherited on the same region of the same chromosome. So it's on the short arm of chromosome 6, and they're all inherited together, and which is why we have essentially Mendelian genetics going on here. So you see the patient has inherited one red chromosome and one from the mother, and a yellow chromosome from the father, which makes the patient. And so this sibling over here is a full match, inherited the same chromosomes, whereas these siblings, this sibling has the same red, this sibling has the same red, but this sibling is a total mismatch. So, again, each sibling has about a 25% chance of being HLA matched. You additionally have to have the sibling lack sickle cell disease. So they also have a 25% chance of having sickle cell disease. So you have to manage that. And if you try to look toward less well-matched donors, historically, the outcomes have been much, much poorer. And so this really is a challenge. So some patients with sickle cell disease, will have matched siblings, but really not all of them. And then looking at the unrelated donor pool, because this is another option. If you had a well-matched unrelated donor, potentially could be considered for transplant, but looking at the patient populations that need transplant. So this is what percentage of people, registry searches for patients of Caucasian descent compared to African American descent will have a fully matched donor. So if you're white and from Western European descent, you'll have about almost an 80% chance of finding a donor in the registry, whereas if you're African American, you have less than a 30% chance. So this is a real big problem for our patients who may be interested in curative therapies and don't have matched siblings. And additionally, we can consider outcomes, transplants from unrelated donors, but the outcomes really historically have not been as good. So in blue is your HLA matched sibling outcomes, and this is event-free and overall survival. A lot of the events here are actually transplant failures and not necessarily death. So you can see they're salvageable in terms of overall survival. And then you have other other donor options, including half-matched relatives, unrelated, matched unrelated donors, and mismatched unrelated donors. And you see that the outcomes really are poor in these patient population, in these donor populations. So we talked about donor matching. In order to find a matched sibling, you have to have your 25% chance of having a sibling who's a match, and another also has to be free of sickle cell disease. It's very hard to find donors for these patients in the registry. Patient age is also an issue. Older patients have higher risks from transplant. We have sickle cell complications and organ function. They may not have great baseline organ function. If they've been chronically transfused, they may have alloantibodies. So that poses a problem. And risk of transplant-related complications is a really big one for these patients. Chronic graft versus host disease can be really devastating after a transplant, especially in its severe forms. And you're running the risk of trading one disease for another. So if they trade their sickle cell disease for chronic graft versus host disease, it may not be as hopeful as we would like it to be. So what if we can overcome many of the barriers to transplant? So these are some of the problems we've talked about: donor availability, alloantibodies, so antibodies against donors, maybe mitigating some of the risks associated with poor organ function. If you get a transplant, you need to be on chronic medications for some period of time, not for life, but for some period of time. And patients with sickle cell disease, they may not tolerate that. Their organs may not be good enough to tolerate some of those. And how about lowering some of the risk of transplant-related complications? So I'm going to talk a little bit about gene therapy to spoil a little bit of a spoiler, but this is what we're going to talk about. So gene therapy, put into Google just like that, gives me a nice AI overview. This is what it tells me. Gave me this picture that it pulled from this article, which was actually a great article. Gene therapy is a medical approach that aims to treat or prevent disease by modifying person's genes to correct the underlying genetic problem. It works by replacing a mutated gene with a healthy copy, inactivating a faulty gene, or introducing a new gene to help fight disease. This can involve techniques like gene addition or more precise gene editing, and with the ultimate goal of restoring normal protein function and altering the course of disease. So this is what AI overview told me. So let's break this down a little bit. Gene therapy can mean different things nowadays. And one common categorization that we use is in vivo versus ex vivo gene therapy. So ex vivo gene therapy, they've both been around or been in research about the same amount of time, but I think ex vivo gene therapy is a little bit more commonly understood, which is where you take a patient's cells out of their body, manipulate them in the lab, and then reinfuse them into the patient. Whereas in vivo gene therapy takes a gene, that's kind of directly infused into the patient. They go to where they need to go and kind of do their thing. So we're going to go through these in a little bit more detail. They both just, so it's clear, apply only to monogenic disorders. You can only do this if you know the gene that's abnormal and there's one gene that you're targeting. It's very difficult to have, to fix someone's risk for type 2 diabetes like this. It's a very polygenic disorder, so that really doesn't apply. So all of these apply for disorders which are caused by a single gene that we know about. So just to compare in vivo and ex vivo gene therapy, so this is a simple one. So in vivo gene therapy occurs in the body. You correct the tissue within the body, something that may not be easily removed. A liver is not easily removed and manipulated outside of the body, but blood stem cells are easy to remove. We do it all the time for other reasons, and we can correct that tissue outside of the body. So anything you can think of this, anything that could be corrected by fixing your blood system can be corrected by ex vivo gene therapy. Anything else probably needs to be done in vivo. Ex vivo gene therapy manipulates cells using integrated viral vectors. So these are your retroviral vectors, lentiviral vectors, things that are going to incorporate into the genome of the stem cell and stay there. There are also newer gene editing techniques. People have maybe heard about CRISPR. There are also other newer gene editing techniques that are kind of coming of age and are all ways that we can do ex vivo gene therapy manipulation. For in vivo gene therapy, you're using an AAV, stands for adeno-associated virus, and these are viruses that have specific tropisms to different tissues. So you have to deliver the gene in this kind of viral capsid, this empty viral capsid that you're using, and it goes to the target tissue and does not integrate into the genome. So it's a non-integrating virus. It lives in like an episome and an extra chromosomal piece of DNA, and it stays there for as long as those cells that have been kind of infected are still around. So some examples of this for in vivo gene therapy, hemophilia was the first one that was really approved, and it was hemophilia B. That was the first. Now I think there's also hemophilia A. SMA, spinal muscular atrophy, is actually directly intrathecally, retinal dystrophy directly into the eye. And so you can use viruses. Hemophilia is for factors that are made in the liver. So they use a virus that has liver tropism. And they really need to go directly to their target organ. Whereas ex vivo gene therapy, basically anything that you can cure with a stem cell transplant can be cured with ex vivo gene therapy if you know the gene. So sickle cell has been the one that we're talking about here. Beta thalassemia uses the same viruses and the same vectors. There are some forms of severe combined immune deficiency that have been cured with gene therapy, and actually that was the first disease that was really studied for gene therapy, and MLD, a couple of different other ones. In terms of in vivo gene therapy is a lot more scalable. It's the same therapy for any given patient, whereas ex vivo gene therapy has to be manufactured for each individual patient. You have to take each individual patient's stem cells, do your gene therapy process, and then reinfuse them back. So for each patient, it's a different process. In vivo gene therapy is just infused into the patient. Usually requires some form of immune suppression because these viruses are immunogenic. And if they generate an immune response, they might not be as effective. I think there are newer techniques for in vivo gene therapy that maybe kind of get around some of this, but this is really historically has been how they have success. Ex vivo gene therapy is essentially an autologous transplant where you really need to use high-dose chemotherapy to clear a stem cell niche for these new cells. And so there's a little bit of a different process for that. For in vivo gene therapy, it's a little bit of a less complete correction. Again, it's a little bit harder to get your virus to get your gene to where it needs to go. Oftentimes those symptoms will be ameliorated. There are more advances that are making this more successful, but it's not as straightforward as ex vivo gene therapy, where you have a better phenotype, you're integrating into stem cells, they're likely to last longer. With in vivo gene therapy, the cells that are infected at the time that you infuse are the ones that are going to generate, but if there's turnover, that may not last forever. There are limitations in vivo gene therapy for the size of the gene that can fit into the adeno-associated virus, the capsid of the virus. Hopefully they're overcoming those limitations with some of the other techniques for in vivo gene therapy. And then for ex vivo gene therapy, there are really late effects of high-dose chemotherapy that you need to worry about. Insertional oncogenesis has been a problem historically. I'll touch upon that in a minute. And for in vivo gene therapy, there are actually like many, I talked about one very kind of advanced one, but there are other ones. There's an siRNA therapy, so a small integrating RNA therapy that was just approved for hypercholesterolemia. There are some topical gene therapies out there. So this is really coming. And in terms of ex vivo gene therapy, it's really, the advances will come, and there are newer ways to do some editing. There are newer ways to do conditioning that we're trying to optimize that will really help reduce the risks of this procedure. I'll go through this a little bit quickly, but in vivo gene therapy, this is a timeline. So again, this started really in the 80s and 90s by, the research for this started in the 80s and 90s. The first human trials were really done in the kind of early 2000s. They, didn't really work at first. They figured out how to make it work with a little bit of immune suppression, and now they're really doing a better job with that. And this is gene therapy. There are a couple of approved gene therapies, in vivo gene therapies out there. These are not done by transplant physicians, just for informational purposes. These are done in different settings, in specialized centers. Whereas ex vivo gene therapy is really kind of a fancy stem cell transplant, and this is performed by stem cell transplant physicians. Again, this is the timeline. Most of this work was done in severe combined immune deficiency and SCID. The first transplant for SCID was done in the kind of early 70s, that proved that you can replace stem cells with working cells. And that would cure your problem. The early viruses, gamma retroviral vectors, using those, we learned that we needed to use a little bit of conditioning therapy to make space in the bone marrow. In the kind of late 90s, early 2000s, there were several trials done of gene therapy for SCID, and there were many cases of insertional oncogenesis that really shut down that effort for quite some time until better viruses were made. And nowadays there are various forms of severe combined immune deficiency and other immune deficiencies that are able to be targeted with gene therapy. None of those are approved. We're mostly because of the rarity of those conditions. Whereas the hemoglobin disorders development happened a little bit later, but really was able to move forward because there's enough of a patient population to move those forward. And this is where we talk about the therapies that we're going to talk about today. There are a couple of metabolic and CNS disorders. As I said, MLD and cerebral ALD have been looked at with using gene therapy. So this is a process for gene therapy. This can be applied to many, but I'll talk a little bit about it in terms of sickle cell disease. So patients' stem cells can be collected by mobilization and apheresis. If you have sickle cell disease, even before this, you need to undergo an evaluation. You need to ensure that you're off hydroxyurea, that you're maintaining, you'll get a few transfusions before this. And this collection process for a patient with sickle cell disease is a little bit of a longer process because of the drugs that we need to use for them specifically. But this collection process happens over the course of a couple of days. Then these stem cells go to the lab. They get enriched for stem cells. They get cultured and processed here. This process takes really at a minimum a couple of weeks, but can take even longer depending on manufacturing capacity and whether you had adequate, whether your process was adequately optimized. And then, oops, I'm just gonna move through these. And then the patient, once it's ready and you have enough cells, the patient comes into the hospital and gets their autologous transplant. So they get their busulfite, their chemotherapy for this, and then the cells are infused into the patient. And this process is a little bit of a longer process. It takes probably about 4 to 6 weeks. There are risks associated with that, similar to the risks of transplant, of stem cell transplant, of high-dose chemotherapy. But after this, we hope that the patient is then cured of their disease. So a little bit of an arbitrary point to tell you that I'm talking about gene therapy for sickle cell disease, but there are two major approaches. There are two at the present moment, there are two approved products and they have different techniques. One is gene addition. So we add a normal hemoglobin gene into the mix of the patient with sickle cell disease. We know that patients with sickle trait have a normal phenotype, and so we feel like this will be successful. The normal hemoglobin gene that's inserted actually has a modification on it that induces anti-sickling properties, and also as a side benefit allows us to follow this hemoglobin, so it's tagged. And this, through this way, using a lentiviral vector, we can insert this normal cell into the patient's stem cells, and then they can produce more normal cells with normal hemoglobin. The other approach that's used is a gene editing approach using the CRISPR-Cas9 system, which uses makes use of the fact that patients with hereditary persistence of fetal hemoglobin really have minimal to no symptoms. And so if we can replicate this phenotype, we will be able to ameliorate the patient's sickle cell complications. So if this hereditary persistence of fetal hemoglobin was identified to be associated with variants in a specific region of a specific gene, this BCL11A gene. And what this does is this gene is involved in turning off the gamma chain, that gamma chain that makes hemoglobin F. And so if we turn off this gene, the patient will revert to making more hemoglobin F. And this is what this does. And so this gene editing technique mimics this hereditary persistence of fetal hemoglobin and allows the patient to produce much more gamma chain compared to beta chain and makes normal hemoglobin F to ameliorate the symptoms of sickle cell disease. So comparing both of these techniques as curative therapy for sickle cell disease. So both of these are intense processes. Both of them require about a 1-month admission in the hospital with potential transplant-associated toxicities. I would say the one difference that in terms of stem cell transplant, that can get off the ground now, whereas gene therapy, you have to make the product. Gene therapy is a shorter time on the back end, whereas stem cell transplant, you're under the care maybe for a little bit longer frequency of follow-up, eventually tapers off. For stem cell transplant, you really need a matched donor or a trial. Trials of less well-matched donors are out there, but the outcomes have not been so successful, so they are not standard of care. Whereas for gene therapy, you don't need a donor. The donor is yourself. You don't need to find a match. All you need is you. There's no risk of graft versus host disease with gene therapy because of the donor, because you're your own donor, whereas with a stem cell transplant, there is that risk, which is why some of these trials have been, why some of the techniques have been problematic. As I said, stem cell transplant has a shorter lead time. If you have a donor, you can go once you're evaluated, but the follow-up after a stem cell transplant is a little bit more intense for a little bit of a longer period of time. And that's assuming that you don't have long complications. Gene therapy takes time to manufacture, so you have shorter follow. But once it's done, you're kind of done. Both gene therapy at this point in time uses myeloablative conditioning, so very high intensity conditioning, chemotherapy before the gene therapy. In stem cell transplant, we have different approaches. You can use high dose chemotherapy, but there are also some reduced intensity approaches that might be appropriate for certainly patients with comorbidities or older patients, but even in some younger patients as well. There's post-transplant immune suppression with stem cell transplant. It's not lifelong, but it does for at least a year. There's no immune suppression with gene therapy. In post-transplant immune suppression is what creates a lot of the post-transplant follow-up and complications. You don't have that with gene therapy. At this point in time, gene therapy is more expensive than stem cell transplant. I hope that equalizes. But the cost of the drug here alone is $2 to $3 million, whereas the cost of acquiring graft for transplant is a couple $100,000, or not even that much. The stem cell transplant has many decades of experience. It's a tried and true method. It does have its own complications, but we know the risks. Gene therapy, we're getting there. We've had about maybe 10 years of follow-up for some of the earliest patients treated, but there's a little bit less experience with that. So if you're a less risk-averse patient in terms of knowing what might be coming, that might be something you want to consider. There's a risk of secondary malignancy with stem cell transplant because of the chemotherapy. Sometimes for some approaches, they use a little bit of radiation. That's a problem. There's a risk of infertility for both of them. And there's a black box warning for leukemia associated with the lentiviral form, so the gene addition forms of gene therapy. I'm going to talk about that in a couple of slides, and we'll explain why it may not be as scary as it sounds, but that's a black box warning on some of them. This is another table. I'll try to point out what's different. I've talked about many of them. You know, you need a donor for transplant, but not for gene therapy. This table differentiates between gene addition and insertion versus gene editing. And so this is, you know, this is your gene addition. This is your CRISPR, and there are other forms of base editing that are kind of in research phase. Again, this is a little bit faster transplant, whereas your gene therapy takes a little bit longer. This is the upfront time that you need. There are no problems with genomic inserts for transplant, whereas for gene addition, you have a little bit of a, you know, semi-random process. Gene editing is a little bit more precise, not perfect, but a little bit more precise. And then, you know, this unique risks, immunologic complications from transplant. This is graft versus host disease. Gene addition has insertional oncogenesis as a problem. Again, this part really is a problem for gene therapy in general, and in specific for sickle cell disease has not yet been identified. And then there can be off-target effects for gene editing or base editing, even as specific as we think it is. A word about malignancy and leukemia and sickle cell disease. There were 2 cases of AML that occurred in patients treated on the first gene therapy trial. This is the lentiglobin BB305, that's a lentiviral vector. Both cases were determined to be unrelated to the viral vector. This was the viral vector problem, and insertional oncogenesis was the problem in the early SCID, severe combined immune deficiency trials in the late 90s and early 2000s. So it's really been something that people who do gene therapy have thought about, but that was not the problem here. One case didn't even contain the viral vector. The leukemia didn't even contain that viral vector, and the other one it did, but it was not felt to be insertional oncogenesis. It was not in a portion of the genome that would have caused a leukemia. Nevertheless, these 2 cases got the addition of the black box warning on the product. But the thing about sickle cell disease that people don't always realize is that there actually are higher than expected rates of hematologic malignancy of blood cancers in patients with sickle cell disease than the general population. And so I don't know if you can see, but rates of AML in patients with sickle cell disease without transplant or without gene therapy are almost 3.5 times higher than the general population. The absolute risks are still not high, but they are higher. And this is a study in California that had 27 years of follow-up. And this is a study out of England with about 15 years of follow-up. And again, you see that the rates of relative risk of AML in these patients is almost 11-fold higher in this particular study. So although again, absolute risk's not that high, 8 patients in this cohort, but still much higher than you might expect. So the etiology of this is not clear. Clonal hematopoiesis, which is, as it sounds, it's an age-related phenomenon, is maybe higher in patients with sickle cell disease. Is this chronic inflammation, stress hematopoiesis, accelerated aging, long-term hydroxyurea use? We really still don't know, and I think there's still a lot to be learned about the relationship between sickle cell disease, hematologic malignancy, and the gene therapy that we're giving. In 2025, gene therapy for sickle cell disease has treated about 100 patients in the US between the ages of 12 and 50. That's the approval is currently for patients over the age of 12. There have been no graft failures or rejections, and patients are maintaining their non-sickle cell disease status up to 10 years out from gene therapy. There have been the complete resolution of severe vaso-occlusive events in 95% of patients and 100% of pediatric patients at a median follow-up of 48 months. Just to note that patients with more than 10 VOEs annually are more likely to have chronic pain post-gene therapy, which you can see in this graph. So you can see patients above here in tan are those that had less than 10 VOEs per year at baseline. These little dots show different VOE events before treatment. And you see down here at the bottom, these blue-lined patients have much higher density of these dots beforehand. You see that most patients up here had no VOEs. There was this one patient that had had other medical reasons for having more pain events kind of in this time period. But down here, a couple more patients with kind of chronic pain that lasted a little bit beyond their gene therapy. So this time 0 is the time of gene therapy before and after. And you can see months of follow-up and the percentage of hemoglobin A, so that marked hemoglobin that we talked about with the little tags. So they really are maintaining about 50% hemoglobin A, marked hemoglobin A. There have been a couple of deaths in these patients, 2 deaths, so there were the 2 leukemia deaths that we talked about, and then 2 deaths. One was in the Bluebird gene addition study that happened sudden cardiac death happened 24 months after gene therapy. That was felt to be related to the patient's underlying history of sickle cell disease. And 1 death in a patient in the base editing technology. This is not one that's currently approved yet, with a history of vaping, had respiratory complications after gene therapy, with inconclusive autopsy findings. So unclear if it was related to the history of vaping in the setting of sickle cell disease, the chemotherapy that we use for transplant. No one would speak up to. There was no conclusion on that. Here at Hackensack, we treated our patient more than 5 years ago, who was a patient in our care, or Dr. Rifkin's care, I think since he was 3 months old. For the 3 years prior to gene therapy, he had 1 or 2 admissions a month for pain crises, despite hydroxyurea. He had no matched siblings, and he received his gene therapy on trial on on the early clinical trials, and he continues to do well 6 years later. He has had no pain crisis since undergoing gene therapy. Since then, we've done 10 more patients, and we have 6 awaiting infusion. And there I will stop. I hope that was helpful and clear, but I think we'll take questions now.
Yes.
I think there are questions you're asking us, right?
Yes, so we'll jump into the Q&A. Feel free to drop any questions that you may have for the speakers today, and we'll answer them here live. You can do that by dropping that in the Q&A section chat. Yes, I think there was yes, go ahead.
So I think one of the questions that, while people are thinking about questions, I think one of the questions that usually is asked of me is how, what is the criteria to actually that we're using for gene thaeraPy? So the original criteria to be on the clinical trials were that patients needed to be hemoglobin SS and hemoglobin S beta thalassemia, and they had to have a history of 4 vaso-occlusive crises in the previous 2 years. And they could be painful crises, they could be splenic sequestration, they could be acute chest, any type of crisis that was documented. The other thing is that the painful crises needed to be patients had to come at least to the ER and get some type of treatment. When the FDA approval went through for the 2 major companies, the insurance companies really are abiding by the original criteria of the clinical trial. So, they really are requiring us to document in order to get insurance approval that the patients have the same criteria. I think another question that a lot of the time comes up is, have we had any issues with insurance companies? Almost all the insurance companies in New Jersey, including all of the Medicaids, have actually approved patients to get this as a commercial drug product once it was FDA approved, and patients were older than 12. We still have the clinical trial open. It has accrued all the patients. It's open from 2 to 12. But right now, anyone over 12, if they fit the criteria, can actually qualify for this. I don't know if anybody has questions.
I think one of the interesting things about sickle cell disease and gene therapy is that, gene therapy was in the initial trials of gene therapy back in the 90s and 2000s were with these really rare diseases that even though they had success in their trials, ultimately, once they worked worked out the kinks over a few decades. It's not something that really was kind of viable from a production standpoint. They really live in academia, whereas this is enabled there's enough market for this to actually kind of be available to many, many other patients. And I think that that's really, I think one of the big things that is talked about is cost of this therapy. People are hopeful that as a little bit of time goes on, the cost and we prove it worthy, the cost will start to come down. It's been a barrier a little bit in Europe to getting some of these therapies there, has been cost because of the differences in healthcare systems.
Just to add to Dr. Spitzer, I think that we are very lucky in New Jersey because across the country, there's also issues organizationally, statewide, insurance-wise in some of the states, and other equity issues that have come up, with just being in this space and talking to a lot of people around the country. We're lucky in New Jersey that we really have not run into any of these issues, that we really can serve our state and our population of sickle cell patients and really not have a waiting list like they have in some states.
I think, this is a very detailed process and it's a very overwhelming process. And I think, patients have to be a little bit motivated, but, at the end of the day, these patients do really well. And even though it seems like a lot going in, at the end of the day, they really are happy with the outcomes. There are, as Dr. Rifkin said earlier in the talk, having sickle cell disease is not just that you have pain crises. There are a lot of, end organ damage that can happen. These patients don't have normal life expectancies. And this can really be transformative despite the risks and despite kind of the intense upfront therapy. At the end of the day, these patients really do quite well. I can't wait to see how they do in 20 years.
Thank you. Yes, if we don't have any more questions, I do have a question. If you could talk a little bit about this. So you outlined a couple of the curative options, so stem cell transplant and the newer gene therapy. So can you talk a little bit about when a family is considering these paths, like what does that conversation look like? What are some key points, factors that you mentioned to the family to consider?
So I think that depending on, when I meet patients as a hematologist at 2 weeks of age, when patients are referred for the newborn screen, we talk about sickle cell disease, we talk about what it's going to look like, but we also talk about curative therapies. One of the criteria for gene therapy is to not have an HLA matched sibling. So even at 2 weeks of age, we talk about HLA typing both the patient, if they have siblings. So we talk about that. So we really have almost 100% HLA typing on our patients in our sickle cell population here at our hospital. And we know if they do have a match, it is standard of care for the patients to go to transplant and have that conversation, an opportunity to go through a stem cell transplant, because having a matched sibling transplant is a great outcome. But if you don't have that, then those patients can actually be candidates for gene therapy as they get older. So we kind of forecast what's going to happen. We start them on disease modifying therapies, and then we follow them and we see if they fit the criteria. We're hopeful that in the next 5 to 10 years that the criteria, the restrictions of doing it for only severe patients or patients with, a certain amount of crises will actually be lifted.
There's a question about why gene therapy only lasts for 10 years. So gene therapy in theory, can last for longer. We don't know. We only have about 10 years of follow-up on the initial gene therapy trials for sickle cell disease. But we do know in patients who had gene therapy for other indications, like the gene therapies done for severe combined immune deficiency in the early 2000s, there are some patients who are out, 20 years and still have good outcomes from their gene therapy, are still cured from their underlying disease. So it's not that it only lasts 10 years. Right now, we only have follow-up for 10 years for sickle cell. It's a great question. And I think, this treatment is still in its childhood. I don't want to say it's in its infancy, but I think we're getting there. We really do have good success. And there are really many new things coming. One of the most exciting things coming to gene therapy is to be able to get away with not as intense chemotherapy upfront. And to use newer techniques to allow to make that stem space in the stem cell niche to allow those cells to be accepted without having to use high dose chemotherapy. And so there are techniques that are being studied. I foresee that in the next 5 to 10 years, that will be an approach that will be more commonly used than kind of like the sledgehammer of high dose chemotherapy, more targeted approaches. And I think that may really shift some of the use of this therapy if you don't have to have the intense chemotherapy. So something to look out for in the future.
There's another question here. Is there any hope of using these techniques on other illnesses like chronic pain?
So I think that in terms of these techniques for gene therapy, again, the real issue is that you have to have a gene that you're targeting. So any disease with a single known gene that causes it, or any gene that causes a disorder, monogenic disorders can really be targeted with some form of gene therapy. Those that are in blood stem cells that can be cured by manipulating any part of the blood system, can be cured by ex vivo gene therapy. Other disorders that are in, for example, many of your clotting factors are only made in the liver and therefore can only be cured by putting a new gene in the liver. You can't make it in your blood stem, in your blood stem cells.
I think also the slide that we had that was the swim lane slide. I think that slide and the concept of having more VOEs prior to having gene therapy, and then these are the patients that are at the bottom of half of the slide. Those are the patients that are more likely going to have chronic pain after. The reason being is that these patients have end organ damage to either their bones, their muscles, or their nerves. So they will have chronic pain syndromes afterwards because they're having more VOEs. So the idea would be to actually not to do gene therapy earlier in life and not let sickle cell actually have so much end organ damage. So then the patients will not have chronic pain. So I think that, and we see this not only in gene therapy, but we also see this in transplant for sickle cell disease. It doesn't remove chronic pain if the damage has already been done. It arrests, both of them arrest sickle cell disease at the point that we do it.
Dr. Rifkin, do you want to take this question? Do you see us doing gene therapy in younger populations for sickle cell?
Yes.
Yeah.
Yes. Our clinical trial that's currently open is down to 2 years of age, and it's closed to accrual. So we'll have that data that will be able to go to the FDA, and hopefully we'll be able to approve this down to 2 years of age. So we are very hopeful that this will be something that will be earlier.
And then I think this one I can take. Theoretically, if the effects of gene therapy were to fade over time, would it be possible to repeat gene therapy treatment to re-up the efficacy? So I think that, for ex vivo gene therapy, that's a great question. With the current adeno-associated viruses that are used, and if people generate an immune response to them, that becomes a problem. But I think there are newer techniques that are in the works that might kind of overcome the viral vector problem. Because you're introducing the virus, it's a benign virus and you've gutted it, but it can still generate an immune response. So that's a problem with in vivo gene therapy. With ex vivo gene therapy, it's another problem because I don't know that the FDA would allow us to manipulate cells twice, and that might be a barrier to those patients.
So the other thing is in the data from the two companies, they actually have shown that over these 10 years of gene therapy, there's a consistent amount of there's a consistent amount of the new hemoglobin A in the lentiviral vector type of treatment, the gene addition, and they actually have shown that translates to a consistent hemoglobin. And it's the same with the hemoglobin F, that it's consistent hemoglobin and consistent hemoglobin F over these 10 years, that it doesn't actually decline from the time that you actually do the initial gene therapy.
Right. And these are the ex vivo gene therapy is incorporated into stem cells. So we expect that those stem cells will have long lives. Those are there are long-term populating stem cells there. Those are expected to stick around for the life of the patient. And we know patients who have had transplants for sickle cell disease and other disorders, those patients are out decades and decades and are healthy, cured of their underlying disease. So we expect that to last longer than the in vivo gene therapy that can sometimes, if you have cell turnover, those cells may not have been exposed. They really try to do that in organs without a lot of cell turnover. So there's some cell turnover in the liver, but not a lot. Nerve and eye are things that don't have a lot of cell turnover. A great question. All right.
I have one last question, just to give some time for any last minute questions since we're almost time for the lecture. So I really like that you brought up the last slide of the patient successful treatment. So what gives you the most hope for the future of treating children with sickle cell diseases?
I mean, I think the most hope is when we're done with actually treating gene therapy and a child who has been admitted for so many admissions per year or having so many crises per year can do something that they've never done before. So when the kids who are treated, when they can go skiing, which is something that usually patients who have sickle cell don't do because they actually will have crisis. When they can do something like that, when they can just go down to the Jersey Shore and put their foot in the water and not have a crisis, that's great. I mean, things that they don't have to be afraid anymore to, that something will cause a crisis. I mean, I think that's really, gives hope about the future for this, and I think it's really important to be able to continue on with this and to continue to make this equitable for everybody.
Thank you. Thank you, Dr. Rifkin-Zenenberg. Thank you, Dr. Spitzer, for your time, for your insight and your experts. It's honestly a pleasure to have you both join us today. And also thank you everyone for participating and asking questions and just, registering for this amazing webinar today. If you can go just to that last slide, Dr. Spitzer. Yes. So if you have any questions or if you want to learn more information, please go to our HMH Children's Health page and you can scan the QR code to your right to learn more there. But this is the end of the webinar and we will upload the recording, which will go to your emails if you want to look back of this webinar. Well, thank you all and have a great day.
Thank you.
Thank you. Take care. Bye.